Hello, everybody. My name is Dr. Jared Hassler. I'm a kidney pathologist. I work at Philadelphia at Temple University Hospital. I'm also an IgA nephropathy patient. My wife donated a kidney to me 11 years ago. What I'm going to be talking about today, all the other biopsy words are. So beyond the top line where it says IgA nephropathy, we now have a much better idea of what that means. Why does the pathologist keep putting a lot of other things in there? I'm going to go over that with you guys. Okay. All right, so we're going to go over number one, the processing specimen itself. So Dr. Barrett gave a great jumping off point where you have that needle that goes in, takes a core of tissue, and then what happens to it? I've already got a question in the back. Yes. Okay, sorry about that. Typically, I have two volumes. One is breaking your eardrums, and the other is barely audible. So I will attempt to, number one, slow down. I speak very fast. Number two, I'm going to try to talk a little bit louder so that everybody can hear. Okay. No. But today, again, we're going to go over what happens to the tissue once that nephrologist or that radiologist takes it out of you. We're going to talk about what I see under the microscope. I'm going to show you pictures. And we're going to talk about the MEST-C score that they sometimes, well, not sometimes, now they should be giving you with every biopsy that has a diagnosis of IgA nephropathy. All right, and then we're going to talk about why. Okay. So next part I'm going to show you, okay? So once we actually take that piece of tissue out of you, what happens to it? It goes into the pathology lab, and what we're going to do is we have a process called grossing. That's just where we put the tissue in a little plastic cassette. It goes into a machine that has this fixation and other processing materials, and it ends up as a block of tissue, literally like a wax block where that tissue is. And then they're going to cut a very thin section of it and put it on a glass slide, and they're going to stain it. I'm going to show you an image of some of those things. So again, this technically isn't kidney, this is brain, but this is the best one I could show you of what the of what the plastic cassettes look like. So we take all the tissue that the surgeons, anybody takes out of patients, we have to cut them into small pieces to put in these plastic cassettes so that we can make glass slides and look under a microscope. And again, that's mostly what I'm doing, is looking under a microscope and giving a diagnosis. All right. After it's become that wax block of tissue that you see right here, it goes on something we call a microtome, and we cut very thin slices of it. I call it a deli shaver. All right. Every time they turn this handle on the side here, where you see that hand there, it's going to move it forward like a half a micron of thickness. And so we're cutting very small, thin slices that we put on the glass slides, and then we stain. And that's what I get when it comes to my office, is this glass slide that has a picture of your biopsy, a picture of your kidney on it, okay? All right. And when I'm looking at your kidney, I'm going to be focusing on the 4 parts of your kidney within the cortex. So Dr. Barrett talked about all those pipes and tubules. I'm going to definitely be looking at that. Those are what we call the tubules in the interstitium, okay? I'm going to be looking at the glomeruli. We've talked a lot about the glomeruli. That's a very important function here. I'm going to show you images mostly of the glomeruli and the changes that this disease does to your glomerulus. And then we're also going to talk about the other blood vessels. Technically, the glomerulus is one big blood vessel. It's a bunch of capillaries come together, but we're going to look at the other blood vessels. All right, I really like this image. This is the one I typically use for my residents and my medical students. What this is it shows what a cartoon image of what I see under the microscope, okay? So we have our glomerulus here, a 3-dimensional sphere that we've cut a 2-dimensional slice out of. All right, and you have Bowman's capsule. That's what this is. It's kind of a sheath that surrounds all of the capillaries. And this is a capillary, and this is a capillary, and this is one, and this is one. Okay, so blood flows through here, and this is part of the filtration unit there. They're like little windows. We call them fenestra. That's actually Greek for window. And if anybody knows of the term defenestrate, it means to throw something out of a window. I joke with my med students, hopefully after my lectures, they don't want to defenestrate themselves. Okay, but we have this cell here that lines the inside of that capillary. Okay, we call that an endothelial cell. All of the blood vessels in your body have an endothelial cell lining the inside. The vast majority of them do not have these windows because they're not trying to filter. Okay. We have a cell on the outside. This is what we call the podocyte. And the podocytes, they add their cytoplasm, they smash their cytoplasm to the endothelial cell, and that's how we get a glomerular basement membrane. That's how we filter blood. Okay. The other big thing here is called the mesangium. This is very important in IgA nephropathy. This is where the IgA molecule is going to deposit. This is where all the damage begins in our disease process. Okay, so we're going to focus on this, but also these other ones. Okay, so again, here is a podocyte, and it's throwing out its cytoplasm against the endothelial cell, and that's what makes these glomerular basement membranes. Okay. All right, this is what it actually looks like under the microscope. Okay, so I have those open capillary tubes here, capillaries. Okay, I've got Bowman's capsule on the outside here. Okay, and all on the inside here we call this Bowman space. So once the blood comes through and it filters, that fluid comes through. It's not yet urine. It's only urine until after it's gone through all the tubules. We call this ultrafiltrate. Okay, whenever those podocytes get damaged, okay, you're going to have protein in there. Sometimes you're going to have blood as well. Okay. And again, just another cartoon showing those capillary loops and the mesangium, okay, and the blood's coming in and the blood's going out. And the urine, technically it's ultrafiltrate, is going out here as well. Okay, so this is what I do most of the day is look at people's biopsies and look at the glomeruli and how this being normal, how it's been changed. And this gives me an idea of which disease process I'm dealing with. Okay. All right. Okay, so again, just another look at a normal glomerulus. This is in a patient that had a kidney transplant. This was a surveillance biopsy. They had a pristine kidney biopsy. Beautiful. No disease, no damage, no rejection. Okay, so this is normal. This is what normal looks like. You're going to get to see this in almost every other slide so that we can compare what normal looks like to abnormal. All right, and so we have these delicate ribbon-like glomerular basement membranes, and there's nothing in here. Blood can freely pass through here, and it can be filtered. Okay, we can look at the mesangium here, and there's only about the normal amount of cells, 3, maybe 4. Okay, and this is how it should look. This is how it's supposed to look. I very rarely get to see this as a pathologist because they don't biopsy normal. Okay. All right, next off, I talked about the tubules and the interstitium. All right. Dr. Barrett talked about the pipes and the plumbing, that once that ultrafiltrate comes through, tons of stuff gets reabsorbed and eventually it gets turned into urine. That's what this looks like. This is what normal looks like. Tons of tubules, and they're back to back or like face to face kissing each other. And the interstitium is the part between these tubules. When it's normal, it's actually hard to see. It's actually hard to identify because they're back to back. But once these tubules become damaged, they start to shrink and fall apart from each other, and the space between them, you can actually see it, all right, and it actually is being filled up with scar tissue. All right, this is what when the kidney gets scarred and damaged chronically, and the tubules in the interstitium are damaged, we call this interstitial fibrosis and tubular atrophy, IFTA. All right, for the MEST-C score, this is going to be your T score, and they've swapped it, tubular atrophy and interstitial fibrosis. Okay. So this is another one that we talk about. Last functional part of the kidney is going to be the blood vessels. This is what a typical blood vessel looks like. We have an endothelial cell, actually a bunch of endothelial cells lining the inside, and then a bunch of cells around the outside that help it handle the pressure coming through. All right. And so this is what a normal blood vessel looks like. It's not been damaged by hypertension, by diabetes, by any kind of inflammatory process. This is normal. This is what you hope your blood vessels look like. Okay, so I will talk a little bit later on about the damage and diseases that can happen to the blood vessels in the kidney and what it looks like. And this is why Dr. Barrett is so very hyper-vigilant or very, very focused on making sure the blood pressure is under control. All components of the kidney, the glomerulus, the tubules, and the interstitium, and the blood vessels have to work together. If one becomes damaged, it will eventually lead to damage in the other components. When the glomeruli become damaged, sooner or later the tubules and interstitium will become damaged. If the blood vessels are damaged, everything will be damaged. Okay? So this is why we look at all 4 of these components. This is why we comment on them all. Okay? All right. Next off, some of the stains that we're going to use. A lot of what you've been seeing here is the H&E, the hematoxylin eosin stain. This is the workhorse of pathology. We've been doing this stain for 150 years. It has a great use in pathology, very limited use in renal pathology. Okay, they call it a red and blue stain, but come on, this is pink and purple, right? Right? This is pink and purple. Okay, I call it pink and purple. Okay, the one that I use the most is these 2 stains here. PAS, the periodic acid shift stain. I have to be careful when I'm pronouncing this one. All right. This one is very, very pink and purple. This one really, really highlights all those basement membranes I was telling you about. It gives me very good contrast. I can tell where the capillary loops begin and end, where the mesangium begins. This one really is helpful. Okay. The silver stain, this one is a pink and a black stain. Sometimes it's called the Jones stain. This one also gives me great contrast, lets me really see those basement membranes very well. Okay. The last one is the trichrome stain. This is a red and blue stain. This is a very red and blue stain. It's America all over it. Okay. And this one lets me look at that fibrosis or that scar tissue very well. All right. So having talked about the functional components of the kidney, having looked at the stains that I'm going to use, we're going to talk about the MEST-C score. Now this is the Oxford classification score. Mostly we'll just say MEST-C or MEST-C. All right. But what happened was we understand that IgA is typically a chronic progressive disease. Usually takes years after diagnosis, unless you're unlucky and find it late, before you actually are possibly going to need dialysis. Okay. So since there are lots of different features of this, it's a very individual disease, the pathologists themselves wanted to know, is there any way that just looking under the microscope, no serologic labs, no any other information about our patient, that we can give an idea of how bad their disease has progressed? Is there anything we can look at the microscope and really tell? So a bunch of people much smarter than me, and technically I was in med school at the time, nephrologists, pathologists came together and came up with microscopic features that are specific to this disease that let them know the disease is going to have worse prognosis over time. Okay, so that's what I'm going to explain to you. I'm going to explain what all of those letters mean, and I'm going to show you images of what they mean. All right, so M stands for mesangial hypercellularity. So I showed you what the mesangium is. I'm going to show you more pictures of what it really looks like under the microscope. This is a score of 0 or 1. If it's in more than half of the glomeruli, it gets a score of 1. So yes, I have to count up every glomerulus on these. And sometimes that can get tedious. Like if they give me a lot of cores from a kidney and there's like 150 glomeruli, that biopsy is going to take me 3 hours to look at. And people will come in and bother me while I'm counting. It's like, stop. I was at 67, but I don't know where I am on the microscope anymore. All right. So the E score stands for endocapillary hypercellularity. So what we're going to see is instead of one cell lining the inside of that capillary area, there's too many cells in there. Okay. So if I can see that feature in at least one glomerulus, that's a score of 1. A little bit worse prognosis, higher risk for dialysis. All right, the next one is segmental sclerosis. This is where we're going to see scarring down in the capillary tuft, not the tubules and the interstitium, but in the capillary tuft itself. If I can see that feature in one glomerulus, that's a higher risk for progression to dialysis. Okay, and that would be a score of 1. Next off, we have the tubular atrophy and interstitial fibrosis. So this is scored 0, 1, or 2. All right, basically, how much scarring do I see in the kidney? Specifically in the tubules and the interstitium. About a quarter, about half, more than half. Okay, this is going to be one of the ones that over time is really going to let you know. The higher the T-score, the higher the risk definitely for dialysis. We cannot fix this. Okay, once that scar tissue comes down, it can't be fixed. Stuart, you've got a question.
Yeah, you mentioned dialysis. We talked about end-stage renal disease. not necessarily dialysis, could be transplantation.
Correct. I'm just talking, Stuart said I need to fix my words. Instead of just saying dialysis, say end-stage renal disease. Some patients do get transplanted before dialysis. But yes, your risk for needing either dialysis or transplant. Excellent. Last one is going to be crescent formation. Okay. And Dr. Julian talked about crescentic glomerulonephritis. I'm going to show you images of what that looks like. Okay. So do we see any crescents at all? In how many percentage of the glomeruli do we see it? Okay. This is usually a bad sign, and all the nephrologists are going to usually give very strong immunosuppressant drugs if they see this. Okay. IgA nephropathy is not the only disease that causes crescents, but when we see it, it usually means it's a very active form that you have to treat aggressively. Okay, so like a summary line on a biopsy report would say IgA nephropathy, and then it would explain diffuse mesangial proliferation, like more than 50%. There's segmental sclerosis, and there's like moderate tubular atrophy. Okay, so an M1, E0, as they would give you that MEST-C score. Okay, some people are going to tell me my biopsy never had this. Okay, I understand. If your biopsy this became standard around 2015, where you needed to really give this score to the nephrologist. If your biopsy is before then, it may not have it. Not every person that trains that signs out kidney biopsies has done a renal fellowship. If they haven't done a renal fellowship, they may not give you an MEST-C score. Okay. The other thing is we will talk a little bit about looking at your biopsy and looking at the microscopic description, and if they didn't give you these numbers, can you figure it out from what they tell you? Okay, so let's talk about the M score, mesangial hypercellularity. All right, here is our normal glomerulus. Okay, all right, and we've got these open capillary loops, kind of delicate ribbon-like glomerular basement membranes. And we could take a look and we see that the glomeruli have normal mesangium here. There's not too many cells in the areas of mesangium. I've shown this one here where you can see in this portion of the mesangium, there's a lot of cells here, like 1, 2, 3, 4, 5, 6. It's a party and everybody's invited here, okay? So like we said, this is where the IgA deposit in the kidney. They deposit in the mesangium. We don't fully understand exactly what happens, but apparently this starts to cause those mesangial cells to divide and proliferate, okay? And this is kind of the start of what's happening. So I have to look at all the glomeruli in the biopsy and see if they have this feature or not, anywhere in the glomerulus. All right, if more than half of the glomeruli have that feature, that is a score of M1, okay? AKA a worse risk for end-stage renal disease. Okay. So again, just taking a look at that mesangial hypercellularity here. Okay. Next one is endocapillary hypercellularity. For this one, I have some arrows here showing that these capillary loops, instead of looking like this where it's open, blood can easily come through, I see like maybe one cell lining the inside. There's too many cells here, okay? All right, so that is endocapillary hypercellularity. All right, again, IgA nephropathy is not the only disease that has this feature. But when I see this in at least one glomerulus, that's an E score of 1, okay? AKA worse risk for end-stage renal disease, okay? Many of the nephrologists, when they see this, will sometimes try to treat it with prednisone or other stuff. I'm not a nephrologist. I haven't prescribed a drug in over 7 years. I don't even have a DEA number, so I can't prescribe anything, okay? All right, but a lot of them, when they see this, will try to start some type of treatment, more so than just the ACE inhibitor and the fish oil we talked about. And now that we have more options available, you know, this could be a good feature now, because that means there's something for them to try to fix. Okay, the next one, segmental sclerosis. Okay, again, here's our normal. And when we take a look, we've got some capillary loops that are open here. But this area, I describe it to med students as though my daughter took a pink crayon and just kind of scribbled all over the place. Okay, I can't really see any open capillary loops. There's nowhere for blood to really get in here. This portion of the glomerulus is scarred down. Okay, this is what segmental sclerosis is. This is your S score. If I see this in at least one glomerulus, that's an S score of 1. meaning, again, higher risk for end-stage renal disease. Okay. And like I said, I like E and S much more than M, because if I see this in one, I'm good. I'm golden. It's S1, it's E1. I don't have to sit there and go through every single one of them, counting up, does this one have mesangial hypercellulite? Does this one have segmental sclerosis? It's S1, done. Next off, tubular atrophy and interstitial fibrosis, the T-score. Okay. This is my H&E stain, showing these tubules back to back, or even just like hugging up and kissing on each other, very happy. All right, in this one, this is my trichrome stain. This is that red and blue I told you about, America, right here. Okay. This portion right here has a lot more red, has a lot more normal tubules. This portion right here, the tubules are shrunken. There's a lot more blue. This is that fibrosis, that scar tissue that's being laid down. There's a lot more space between the tubules. Okay. So this is what I talk about when I say tubular atrophy and interstitial fibrosis. There's been damage, all right, they've shrunken down and they've scarred down. Okay. So this is one of the things that I will look for as well. It isn't all just about the glomeruli. I got to see what else is happening in the rest of the kidney. Okay. So this is one of those features. Once this scar tissue comes down, so currently there is nothing we can do to fix it. It will typically only continue to progress. It usually never gets better. Okay. So this is one of the ones that you hope is a little bit better. Okay. All right, and that is our T-score. And again, we have T-score of 0, 1, or 2, meaning the higher the number, the worse your chance for end-stage renal disease is. All right, the last one, we're going to talk about crescents now, the C-score. Here's our normal glomerulus, and then in this one, instead of normal here where the cells that line Bowman's capsule are just nice and normal, what's happened is they have sensed that something is damaging this glomerulus. And sorry, I didn't say this. This is my pink and black stain. This is my silver stain. This is Jones stain. Those cells have sensed that something is going wrong. And so you can even see them lining here. They are undergoing hypertrophy and hyperplasia. They're dividing. They're trying to fix the damage. But the problem is this is a maladaptive change. This actually will end up slowly killing the glomerulus over time. Actually, not that slowly. It can do it quickly. But they're going to fill up Bowman space. Okay. Instead of having this nice open area where all that ultrafiltrate can go to eventually turn into urine, that whole space is being filled up by these cells, trying to stop the damage. This is what a crescent is. All right. And like Dr. Julian said, it kind of has the shape of a crescent moon as it comes through. That's where we get the descriptive term for it. IgA is not the only disease that can cause crescents, but when we see them in crescents, we have to treat it aggressively when we see these. Okay, so usually this is going to be something that if you get a C-score more than 0, your nephrologist is probably going to want to treat it aggressively with an immunosuppressive drug. Okay, they may even want to re-biopsy afterwards to make sure the crescents have gone away. So why do we do this? Why do I give this MEST-C score? So you've already seen a chart very similar to this that Dr. Risk showed, where the worse the protein, the more protein you have, the worse your risk for end-stage renal disease is. It's the same with these features I see under the microscope. The higher your score is, the higher your chance for end-stage renal disease. On the y-axis here, it says survival without the primary outcome. Primary outcome being need for a transplant or dialysis. Okay. At 1 here, your kidney's fine, you don't need transplant, you don't need dialysis. The farther it gets down, the more chance you're going to need that. And this is again going to be in time. Okay. So if we look here, this is a person that has some proteinuria at biopsy, but everything has a 0 on that MEST-C score. As we follow that down, their chance for needing dialysis is less than 10%, or chance for end-stage renal disease is less than 10%. Okay. As you keep adding more numbers, all of a sudden, in these patients right here, they've got some proteinuria biopsy, they've got an M1 and T1 or 2, all of a sudden their chance for needing biopsy is now almost 25% or more. I've got a question in the back. Mhm. Yeah. So the question is this with or without any treatment, like steroids or anything else? So typically, they're going to throw that treatment in the past. Now, again, things are changing now that we have more drug companies willing to put some more drugs out there. This chart may change over time soon. Okay. But we don't really see much of that E score here. Typically, when you have an E1, they're going to treat that. Okay. The steroids and other drugs aren't going to change the T score. Once that scar tissues come down, you're not going to get that out. There are drug companies working on preventing the scar tissue from being placed down to begin with. Nothing that I know of is yet ready for FDA trials. I know that the kidney doctors are very interested in this. The pulmonary doctors are very interested in this. The liver doctors are very interested in this. Okay, because you could prevent cirrhosis of the liver, scarring down of your lungs. That's something that lots of people are looking forward to. But right now, we can't stop that process once it happens. So just wanting you to understand that as you have, especially the T score, but as you have an increasing numbers on your MEST-C score, your risk for end-stage renal disease worsens. All right, so now we're going to talk about some of the blood vessel issues. The vast majority of what I showed you was glomeruli and the tubules interstitium. But I told you there's four components, right? The blood vessels. So some of the things that we see affecting your blood vessels are going to be hypertension and diabetes. Those cause arteriosclerosis and arteriolo. Yeah, I said YOLO. I say that to my med students all the time. Arteriolosclerosis. So the very, very small arteries that are feeding blood into those glomeruli. Those can be damaged by hypertension and diabetes. I'm going to show you a picture of this. This is why your nephrologist really wants you to control your blood pressure. Okay. This is also why, if you have diabetes, you really got to try your best to control your blood sugar. Having IgA nephropathy does not mean you're immune to diabetes or any other disease. Okay. Some of these inflammatory processes, like if you have a transplant, we see transplant rejection, we can see inflammation around the blood vessels. Sometimes, I'm going to show you images, those cells that make the blood vessel, they actually get damaged and they die. I'm going to show you images of that. So when they die, they typically cannot handle the pressure of blood flowing through them. Blood's going to just shatter out and spill to the surrounding tissues. Okay. Thrombosis, aka blood clot formation. We are going to talk about some diseases and specifically thrombotic microangiopathies. This is something that they've asked us to really start focusing on as we look at patients with IgA, lupus, and other diseases. And then emboli. I'm not going to show you any of this, but emboli pretty much just means some kind of thing that can close off the blood vessel that's been thrown down or moved. So sometimes blood clots can move. Many people have heard of a pulmonary embolus, where you have that blood clot in your leg veins, it moves up into your lungs and causes problems. That's what an embolus is. Embolus moves, thrombus forms at the site. Okay, but they're both usually blood clots, even though emboli isn't always a blood clot. It can be other things. Okay, so we're going to take a look at this normal blood vessel I've previously shown you. This is what you hope all of your arteries are, okay? And this is a patient that has arteriosclerosis. This should be all the way open. Okay, here's the lumen. Here's how much blood's flowing through. It should be all the way open, and it's been narrowed at least half. So less than half of the normal amount of blood can get through there at any time. All right, so this is in this patient's kidney, but you have to understand, if this is hypertension and diabetes, almost every blood vessel in your body is being affected like this. The vessels in your lungs, the vessels up in your brain. Okay, this is why it's very important to keep your blood pressure under control as best as possible, your blood sugar under control as best as possible. You don't want to have it so all of a sudden, less blood's flowing through here, your kidney senses that, so then it starts to, because there are blood pressure control mechanism, they start to increase their own mechanisms to try to increase blood pressure as well. All right, and then as Dr. Barrett says, it's a downward spiral. Your kidney's not getting enough blood, it increases blood pressure, the blood pressure damages the vessels more, meaning less blood coming through, it's a downward spiral. That's why we want you to take those blood pressure medications. Okay. Last thing I want to talk about is thrombotic microangiopathy. Long word, we normally just call it TMA. All right. Thrombotic means making blood clots. Microangiopathy means small blood vessels disease. Okay. So typically not in our large vessels like we think of a stroke or a pulmonary embolism or something like that. These are going to be in the small blood vessels, in the kidney, in the brain, in the lungs. We're going to throw small blood clots there. All right. And there's a lot of different diseases that can do this. IgA nephropathy is one that can. Okay, so what we're going to see in this is these type of diseases, you will see small blood clots in those arterioles, even in the glomerulus itself. And sometimes this is going to shatter the red blood cells, and it's also going to decrease your platelets. Okay, so when they do a complete blood count, a CBC lab draw, your platelet count will be low. We call that thrombocytopenia. You can imagine a lot of times when this happens, you're going to have kidney damage. All right. Lots of causes. It's a new focus in IgA nephropathy. The Renal Pathology Society has asked that we make sure to screen for this in every biopsy that we newly diagnose with it. What does that look like? I've got my normal artery here, okay? And one of the things that we can see is this process called onion skinning, where all of these cells that are the muscle cells that wrap around the blood vessel, the endothelial cells, so that it handles the pressure, they're getting damaged and they start to proliferate. This is a blood vessel. Where is the blood coming through here? Where's the open lumen here? Yeah, there's not one. This one is completely closed off. This is one of the things that we worry about in the thrombotic microangiopathies. Again, this is happening in the kidney, but like I said, it could happen in any blood vessel in your body, especially the small ones, like up in your brain. This is one of the reasons why we screen for this now. Here's another blood vessel, and this has that layered look, like an onion, layers and layers. So I think this is the lumen here. Okay, so now this artery has pretty much become a capillary where like only one blood cell can get through at a time. All right, so this is one of the things we worry about in thrombotic microangiopathies, is this onion skinning appearance. The other thing that we can see is necrosis. So again, we still have that onion skinning look, those layers and layers and layers of this blood vessel, and I think this one's completely closed off as well. What you see on this one, this is a longitudinal section. I can't see any of these layers, any of these cells here, because they're all dead. All right, this is necrosis, cell death. I like to describe a lot of times the blood vessels as nice straws throughout your body. All right, if you took a straw, does anybody have those? My daughter just had one of these straws that has cookies and cream. It's got cookies and cream on the inside. You can imagine if the entire wall was made out of that, how much pressure could that handle before it just kind of shattered or broke? That's what's happening here. All of these blood vessels, the cells that line them and make them are dead and dying. Sooner or later, the blood coming through here is just going to shatter out and then spill out here. Anything that needs blood from that vessel downstream is not getting it anymore. This is another thing we worry about in thrombotic microangiopathy. Okay. The last thing is these thrombi, these blood clots. So again, I've got my normal glomerulus, and then here it is just completely filled up. You can't even see an opening where blood gets through because there's a blood clot right here. Okay. And then the rest, the blood is stuck and it can't get out. It can't flow through. Okay. This is one of the only situations where when I see this, I have a nice cushy job, all right, compared to the nephrologist, but when I see this, I have to let them know immediately, this is a medical emergency. They need to deal with this. Okay. And so this is one of the things that we really worry about as well. And it's become a new focus in IgA nephropathy. There are a few studies out there, a few drugs out there by some of the companies that can help deal with this process in multiple different things. Yes, about 10 minutes, okay. So I've got like, I think 1 or 2 slides left. So some people have asked me, well, I've already got my diagnosis, okay. How come my nephrologist wants another biopsy? Here's the reasons why nephrologists want another biopsy. Number one, all of a sudden your creatinine is increasing, much more than they would predict by the previous biopsy and the MEST-C score. Number two, all of a sudden you've got more protein than usual, okay. Something's happening, something's changing. Remember, just because you have one diagnosis doesn't mean you can't have another disease process happening in that same kidney. All right. Last one, concern about your MEST-C score worsening. Especially they're worried that that T-score is getting worse, that there's more scarring, more fibrosis. And lastly, maybe you have diabetes, maybe you have hypertension, maybe you have some other disease affecting your kidney. Okay. They're worried that something else is damaging your kidney. So they're going to do another biopsy and let us see what's going on. Because all of a sudden, that projection that we've kind of given them of when or if you're going to have end-stage renal disease has now changed. Maybe it's faster. Okay, and we want to see if we can do something to try to stop that process. Okay, and that's going to be the end of my talk. I hope it wasn't too technical, but I'm willing to take a few questions. We're going to start with Stuart in the front, and then I got you next.
So if you have a post-transplant biopsy, are you looking for the same things as a biopsy that's done pre-transplant?
So Stuart's question was, if I have a post-transplant biopsy, am I looking for the same things pre-transplant? I'm looking for similar things, but there are new things. In a post-transplant, the first thing I want to look for is rejection. If they're not taking their medications, or some patients take their medications and they still have issues, we haven't got the level right, they're going to start rejecting. That's the first thing I look for. I look for recurrence of their original disease, because remember, when we give you a transplant, we have not cured your IgA nephropathy. You're still making the IgA thing. It can still recur. Having said that, IgA nephropathy doesn't have a lot of clinical significance when it recurs after transplant. You're still taking anti-rejection meds. It usually is going to keep that IgA at bay. Okay. All right. Wait for the mic. Wait for the mic.
Oh, okay. Do you guys have the ability to actually give an MEST-C score after a biopsy was done, like if it was done before the MEST-C scores were even around?
So if there's a microscopic description that describes, I can look over there and I can see, do they say I see mesangial hypercellularity? Do they say the word segmental sclerosis, endocapillary hypercellularity, crescent formation, tubular atrophy, things like that? Yes, you can kind of work backwards and do that. Okay, that's a great question though. And like I said, there may be people in this room now with recent biopsies that don't have an MEST-C score on them. It happens. All right. So what I want you to do is look at the microscopic description. They should all have a microscopic description explaining how they even got the diagnosis. All right. Look if they have the words mesangial hypercellularity, segmental sclerosis, tubular atrophy, crescent formation, endocapillary hypercellularity, those type of things. Okay.
The blood vessels that you were talking about in the kidneys that are destroyed or ruptured or something because of hypertension, high blood pressure.
Mm-hmm.
Okay, once the blood pressure is under control and everything is good, can they be restored, or are they permanently damaged?
Yeah, so that's a great question. So again, understanding that anything I've taken out of the patient is never going to get fixed, but it's representative of what's happening overall. If there hasn't been necrosis, okay, if there hasn't been cell death, there is a chance that it can go back to normal. Once the cells are dead, it's gone. It's just going to scar over and try to do that. That's a great question, though.
So I'm trying to figure out how to articulate this. First of all, fascinating. This is really, really interesting stuff. As the pathologist, you are using the MEST-C score to help make a prognosis of disease. Will the nephrologist be using do they know the MEST-C score, and will they use it as intimately as you do?
So the ones that I work with do. Now, Dr. Julian has done this longer than I've even been alive. He's that good of a guy. And he seems pretty up to date on his knowledge. I would assume yes. The vast majority, especially we talked about, not all your nephrologists are going to be experts at this or whatnot. Hopefully you can get one that does see IgA patients. They will know what to do with it. Remember, this is only a bit of a helpful projection. They're still going to use their serologic tests, what's your proteinuria, what's your creatinine, all of it to come together to get the best idea of how to predict if and when you're potentially going to go into end-stage renal disease. Great question.
Yeah, so if you can get on your iPhone, something called the International IgA Nephropathy Risk Prediction Tool, which is the most up-to-date way of predicting what's going to happen to you within 5 years of your kidney biopsy, and now it will look at out to 7 years. And if you look at that, it's on QXMD, and part of what you put in is your MEST score, your blood pressure, your GFR, your proteinuria, and some other information that should be readily available to you, and it will give you the percentage risk for you and the risk of a doubling of your serum creatinine. And so that's what I do, and that's what lots of people do, and how they use the pathology score, which is absolutely essential to that process, in deciding and giving information to patients about what's likely to happen. So if you can't find it, you come and find me, and I'll show you, and I've got it on my phone, but you can all do it yourself. And it's just, we've just recently updated it, and it's been validated in over 5,000 global patients, and validated, and it's published now. So you can use that to work out your own risk.
Yeah, I didn't even realize Dr. Barrett was in here. Thank you. I'm glad that you and Dr. Julian are here.
I wouldn't miss this.
You got to
no.
give me some clinical
Yeah,
help here, guys.
So I'm sure it's QXMD. I need my glasses. My reading glasses.
You're wearing your glasses.
Yeah, it's my reading glasses I need. Calculate by QXMD. So if anyone can't find it, I'll show you it on my phone.
I've got a question up here as well.
Okay,
and-
and
yeah,
what
yeah,
about-
yeah.
Just raise your hand if you have a question. I just yeah. There you go.
You're showing biopsies of the kidneys. There may be times where you happen to see, for some other reason, biopsies of other parts of the body. What do you see with IgA?
That's a great question. So typically, we talk about IgA nephropathy. There's another disease some people may have heard of, IgA vasculitis. The other word for it is Henoch-Schönlein purpura, HSP. So a lot of those patients are going to have more than just kidney symptoms. We're going to see those most commonly, though, in children less than 10 years old, but those are going to have like a big rash, going to have GI issues and facial swelling and things like that. In terms of what else does IgA do to the rest of the body, I'm going to have to refer to my clinical colleagues because I don't know much. There's some concern about does it affect lungs at all? But right, it's a great question. Right now, I don't know much. For the patients that I've seen that have had a liver biopsy after a diagnosis of that, their liver issues are not related to their IgA that I've found. Okay, but it's a great question. It's a great avenue of research to go down. Does it affect any other organs?
We have a question back here, and then Stuart, you'll keep us honest on time, right?
Yeah, you got
Okay.
Hi. So I had my kidney biopsy about a year and a half ago, and I don't remember exactly the terminology they used, but it had to do with like kappa light chain restriction or something with kappa light chain. And so they sent me to a hematology oncologist, and I met someone else here that was also sent to a hematology oncologist too. And is that related at all, or is it separate?
Okay, so one of the things that we're talking about, and when I talk about the ways that I make diagnoses, I use the light microscope, I use the immunofluorescent microscope, and those give me those green images that Dr. Barrett had showed earlier. All right, and then I also use something called an electron microscope, where I'm looking at like 50,000 times normal human vision to see the ultrastructure of the cells themselves. So when we talk about IgA nephropathy, we know IgA is going to light up bright green on immunofluorescence. Interestingly, the lambda light chain is usually brighter than the kappa light chain. In normal situations, kappa and lambda should be normal, should be equal staining. All right? When they stain differently, it's a red flag to us that maybe there's some type of hematolymphoid issue going on. Maybe you have like multiple myeloma or something going on. So for me, if it's IgA and I see the kappa staining brighter than the lambda, I'd be a little off, but usually lambda is going to stain brighter than kappa. So I got a follow-up question. Did you have to get a bone marrow biopsy? Did they do anything else with you? Everything was okay?
They haven't done anything else yet. I mean, I'm seeing another doctor. Like I've been to him for 2 years in a row, but there's been no change in that. So that's why I didn't know if it was really. And I've tried to Google that,
Okay.
and I
So-
don't find any
yeah,
information.
so I'll talk to you afterwards because that's going to be its own separate situation where they're worried that it's not IgA and it's your body producing a ton of IgA. We call it a monoclonal gammopathy inappropriately because something else is doing it, not this disease process. Okay, but we'll talk about that later. It's a great question. Anything else? I hope this made sense to y'all. I know it can be, I geek out on this stuff. I sit in front of my microscope. I love it. It can be boring to some. All of my pathology colleagues just roll their eyes because it's not cancer. They only care about cancer. They don't care about medical disease. Yeah.
I might just join y'all in that conversation afterwards. I was the one that she was speaking with about I had to see an oncologist as well. When I was having going through my process of figuring everything out. I had I always forget the name, an ultrasound done, and they found that I had an enlarged spleen, and they didn't know if there's any correlation between the two. Is there anything that you would know of that would have any kind of a correlation in that way?
Typically, no. So when we think of an enlarged spleen, there's a lot of things that can do that. Liver cirrhosis, heart failure. I'm not saying you have any of these. I'm just saying. I'm I'm just saying that
I've already processed through all that
you've already
myself. It's
processed
okay.
those.
Yeah.
To my knowledge, the disease IgA nephropathy by itself does not cause splenic congestion or enlargement or anything like that. All right.
Yeah, you mentioned that crescents can go away, and then scar tissue does not go away. What other part of the MEST-C can improve?
So some patients after treatment, their E score improves. Okay, their M score can improve, and a lot of times once we treat the crescents, that C score improves. Typically, the S score doesn't improve, and the T score does not improve. Okay. Now, having said that, for the S score, if they were to take a biopsy and I see one glomerulus and they've got like 20 for me to look at, and it's got that segmental sclerosis, S score of 1. If they take another biopsy later and I don't see any glomeruli that have that feature, that would be an S score of 0. Okay. It may be that we didn't get enough glomeruli and I would find another, but then it seems like it's improved. Okay. But typically that process, it's debatable as to whether or not we can fix that segmental sclerosis process. Great question, Chris. Yeah.
On a biopsy and saw one, where would your thought process be on that? Because that's a pretty good capture on typical biopsy.
Yeah. So typically, this is great. I want, the Renal Pathology Society says I need a minimum of 10 glomeruli for light microscopy to do my job. Okay. And some people think, he said there's millions in there. What do you mean you can't even get 10? I don't take biopsies. I don't know how hard it is. Okay, some patients are a little bit larger. Some patients will move when they do the. I've had biopsies before. They're not fun. I mean, but I don't actually take them myself, so it's really easy for me to make fun of nephrology and radiology when they don't do it right. I don't think that's a fair thing. But so he says correct. But so I need at least 10 to get to be able to say this is generalizable for the rest. Okay. Where's my numbers here? Where's my numbers here? Okay. So if I saw 1, that's more than 0%. That would be a C score of 1. Okay. If it's 36 glomeruli, if it's 150, it's still 1 glomerulus with a crescent. I would have to give it a C score of 1. Okay. If it's only 1 crescent though, and any biopsy afterwards doesn't show them, I would say that process has been kind of tamped down, and that's a good sign. Yeah, I've got one more in the back here.
So you mentioned that not every pathologist is necessarily trained in looking for these specific things. I think renal pathology
You're going to make
is
me throw
obviously
my colleagues under the bus now.
specific.
I'm going to get disowned.
I guess my question is just, is it fair to ask your nephrologist for a second opinion if you feel like these specific scores or some of that analysis isn't necessarily done and you might suspect that?
Okay, so this is a great question. Is it fair to ask your nephrologist to go ask the pathologist for more information or even get a second one? I think yes. All right. You can even ask Dr. Barrett and Dr. Julian, if the pathologist did not give you an MEST-C score with a diagnosis of IgA nephropathy, is that good enough for you? They're both shaking their heads. No. They want the answer. He says they'd be sacked. The British version of, I'm looking for another pathologist to give my business to. All right. At this point, it's standard of care. All right. I've talked to you about how you can kind of reconstruct it, but in today, 2022, if they're not doing it, they need to get back. Then they need to either go do some continuing medical education or go to an away. They need to get back on board. That this is now the standard of care. The nephrologist and the patient need it in order to make an appropriate plan for the future. Got another question here. Wait.
Does your facility throw out the core sample after you've done your
Ooh.
diagnosis, or
y'all are getting really into the weeds on what we do in pathology. Okay, so and I had to memorize all this crap for my board, so I know it. Okay, all right. So the report itself, we have to keep files on that forever. Okay, the slides, we hold on to those for about 20 years. All right, there are warehouses that we have where they go. Okay, the wax tissue block. All right. All right, the wax tissue block, we have to hold on to that for 10 years. Okay, like I said, there are warehouses where these are stored. Okay, the actual tissue itself, say a person has a mastectomy specimen, I'm not going to cut every bit of that patient's breast and put it into there. That would take 1,000 or so. But the extra tissue that's left over, we keep that for about 6 weeks after it's signed out, in case you have to go and cut more. Okay, but so the slides will be around for a long time, the tissue blocks a long time, the report forever, so that we can, you know, get made fun of later on, or hopefully not sued, but you know.
Okay, so I have subject inflammation. I just got my biopsy done in January, and I went through the whole process of steroids and cytoxin, and I didn't respond. At least
Your creatinine didn't lower? Your creatinine didn't lower?
No.
Okay.
And so when would be a good time to like advocate for myself to get a second biopsy done to see if these other things that I'm trying work? It doesn't seem like something my nephrologist wants to do.
Okay, so the question was, she had a diagnosis of IgA with crescents. After she got prednisone and cytoxan, didn't seem to improve creatinine and protein, and is now wondering, is it okay for me to ask for another biopsy and whatnot? So I'm going to have to refer to my clinical colleagues. Me personally, I would want to see it. Once I've seen crescents and you've treated it and something hasn't changed, why? Right? Why? I want to know why. Are there still more crescents? Is there bad scar tissue that's not going to be able to be fixed? I think you need another biopsy, but I'd let my colleagues say whether or not they think it. Again, a kidney biopsy is not risk-free. Okay, and for all of us that have had one, right, it's not fun laying there flat with that stinking beanbag punching at you for like 6 to 8 hours, right, or whatever it is, right? Gosh, I had 3 of those things. I hated. That was the worst part, was laying flat for however long, at least for me.
Okay, I think we have to break because the other group is coming in. We have next session in this room is Finding a Balanced Nutrition in IgAN with Lauren and Anthony. And in B and C is Demystifying Clinical Trials. And if anybody who wants to stay in this room, we also have some fruit and refreshments outside in the coffee area. So you go grab a quick bite. Thanks, Jared.